thank Pat for her wonderful slides giving the background on the GEMS and on the postings, but also on the timeline, because she just made my job a lot easier in terms of what I will cover. And again, what I want to do is just call out the pertinent deadlines for this cycle of reviews, so that November 15, I believe the date is, to get your comments in related to any proposals presented for this meeting. And again, to reaffirm what Pat said earlier, please send email, do not send snail mail. You can send snail mail as a backup if you want your letterhead acknowledged, if you can't do that within an email. But the important thing for us is actually getting your comments, and email is the best way to do that. And within the topic package, you have a page that outlines all of the contact information for the NCHS staff, but we also have a specific CNM inbox, and we really do encourage you to send your comments there. We found it to be quite handy, and it allows all of the staff to access your comments more rapidly because we have one go-to place for all of those comments. One thing that was not covered earlier, CEUs, because I know many of you are still concerned about getting your CEs for these meetings. Information regarding the CEUs is in your topic package on page 10. Again, for those who historically remembered getting hard copy certificates, we no longer do that. Your printing out of the materials is an acknowledgement that you've participated, and that information can be made available to whatever the respective organizations are for whom you are seeking CEUs. And for those who are considering submitting proposals for the March meeting, please note January 17 is the deadline for new proposals, but please know that that is a hard, fast deadline. And I know it kind of sneaks up on people quickly because it's post-holiday season, but that is a hard, fast deadline. And that's because given the number of proposals that we're actually receiving, and given that that deadline is 2 months before the March meeting, we need time to prepare the proposals, review any outstanding issues and or questions about the proposal. So we ask that you absolutely adhere to that deadline. If you're not able to do so, it will be deferred to the September 2014 meeting. And we really can't make any exceptions, and I'm sure you appreciate that and the amount of work that goes into this. So with that, I will now get ready to turn the discussion of proposals over to staff. For some of you who were at either the September 2012 meeting, you'll recall rather that we had new staff that had joined us, but they didn't present at that March 2013 meeting. They will be presenting today, and yes, they are a bit nervous, but I know all of you will be really kind, thank you, in listening to their presentations. You're a great group, we all know that. So, but it's always tough the first time you stand in front of a group, whether it's the group here or knowing that there may be, a couple of hundred people, listening in. But I'm sure you'll welcome them warmly, and everything will proceed quite nicely. We are going to start with proposals again for ICD-10-CM. All the proposals are for consideration for October 1, 2015 implementation, unless noted otherwise in the topic package. And so we will invite your comments on those things, as well as addenda items that are also included in the topic package. And with that, I'm going to turn the podium over to Dr. David Berglund, our medical officer, who will present the first topics.
All right, good morning. And I'll admit that my first thought was the only people I might be wishing good morning to would be maybe a few people listening in from the West Coast. But we are getting an earlier start, and we thank you for that. That's always a nice thing. We will be first starting with periprosthetic fractures. And I'm going to raise this podium a little bit, so my apologies if that seems to make any extra noise, but that just makes it a little bit easier for me to find things and see them. So periprosthetic fractures, for those of you who made printouts of this, it's on page 13 of the handout, and I'll hope that each of you have that and can follow along. Either that or that you have very good memories and can remember what I'm reading and saying. Now, periprosthetic fractures right now are classified in the complications section in ICD-10-CM, and similarly to in ICD-9-CM. In ICD-10-CM, they're at T84.0, mechanical complication of internal joint prosthesis. Now, that placement was based on approach used when it was first added to ICD-9-CM in 2005. It's been observed the ICD-10-CM structure provides opportunity to more appropriately place this concept in Chapter 13, the diseases of the musculoskeletal system and connective tissue. And the American Academy of Orthopedic Surgeons, AAOS, has submitted the following proposal that we'll be going through to make such changes. Fractures happen for one of two reasons. There's either significant trauma, or there's some type of a pathological condition such as osteoporosis, a tumor, or other pathological condition. Fractures around a prosthesis are not a complication of the prosthesis, but just the result of the same conditions that cause other fractures, either trauma or pathological conditions. So therefore, AAOS proposed to move periprosthetic fractures from the complication section to the musculoskeletal section. Periprosthetic fractures can occur around any prosthesis, but the most common ones would be in a hip prosthesis, knee prosthesis, ankle or shoulder or elbow prosthesis. And based on input from AAOS, it's proposed specific codes be created for periprosthetic fractures around internal prosthesis of the hip, the knee, the ankle, the shoulder, and the elbow joints, with laterality specified as either right or left for each of these joints. Index modifications are also proposed in order to be able to specifically identify these periprosthetic fractures. And furthermore, AAOS requested these proposed changes be expedited and be effective with implementation of ICD-10-CM on October 1, 2014. So comments on this also are due by November 15, 2013. And we invite comment both on the proposals themselves and whether the changes should be made, and also on the timing and whether these should be made on October 1, 2014 or before. Now, looking specifically at proposed changes, first at M96, the category M96, where we have intraoperative and post-procedural complications and disorders of the musculoskeletal system not elsewhere classified, it's proposed to add an excludes to type note for periprosthetic fracture around internal prosthetic joint, and this would be to a new category M97. Looking now at that proposed new category M97, this would be titled periprosthetic fracture around internal prosthetic joint, and it would exclude fractures of the bone following insertion of orthopedic implant joint prosthesis or bone plate. This would essentially be during insertion and would be another potential way of having that, and that would be at M96.6. It was at one point suggested that instead of fracture of bone following insertion, it'd be fracture of bone during insertion, and that's one we could contemplate, and I'll invite comment on also. Also, it would exclude breakage or fracture of prosthetic joint T84.01. There would also be seventh characters added to each code from the new category M97. These would be similar to others in this chapter. A for initial encounter, D for subsequent encounter, and S for sequela. We would, at this new category, have a new subcategory, M97.0, for periprosthetic fracture around internal prosthetic hip joint. New codes, M97.01 for the right hip joint and M97.02 for the left hip joint. We would also have a new subcategory, M97.1 for periprosthetic fracture around internal prosthetic knee joint. New codes, M97.11 for the right knee joint and M97.12 for the left knee joint. A new subcategory, M97.2 for periprosthetic fracture and internal prosthetic ankle joint. 0.21 for the right and 0.22 for the left again. A new subcategory, M97.3 for periprosthetic fracture and internal prosthetic shoulder joint. New codes, 0.31 for the right shoulder joint and 0.32 for the left shoulder joint. A new subcategory, M97.4 for periprosthetic fracture around internal prosthetic elbow joint. New codes, 0.41 for the right elbow joint and 0.42 for the left elbow joint. And we would also have a new code, M97.8 for periprosthetic fracture around other internal prosthetic joint. And we'd have specific inclusion terms there to indicate that this would include the finger, the spinal joints, the toe, and the wrist. And we would also have a use additional code note to identify the joint, indicating to use codes from Z96.6. We would also have a new code, M97.9 for periprosthetic fracture around an unspecified internal prosthetic joint. Now, in addition to these, we would have at T84 the complications of internal orthopedic prosthetic devices, implants, and grafts. At 0.0, the mechanical complication of internal joint prosthesis, we would be deleting T84.04, the other code for periprosthetic fracture around internal prosthetic joint, and then also the other specific codes at T84.04. There would also be some index modifications to clarify this, and that fracture pathological, periprosthetic, we would be adding terms for specific joints, similar basically to the ones that we've already discussed. And we would have this both under pathological and under traumatic. So those are the proposed tabular and index modifications. Any comments on either the clinical or the coding aspect of this?
Nellie Leon, she's saying, I actually have a question, and I'm not sure if you can answer this because perhaps this was something that AAOS had already considered. The proposal doesn't tell me whether the fracture is due to trauma or a pathological fracture. And knowing that the external cause of injury codes are discretionary unless you're in a state or someplace else where they're mandated, how would anybody ever looking at these codes would know the difference? Or is the idea that this is just reflecting that it's periprosthetic fracture and that you would still have a separate code for the actual bone, and those codes would then tell you pathological fracture versus traumatic fracture? I'm a little bit confused about the intent of these codes.
Well, that is an excellent question, and certainly with the periprosthetic fracture, there could be contribution from each of those, and if we did not allow for coding of both, we could miss that. We've not put in notes to specify that, but that's an excellent question and point that we probably need to do one or the other. If we don't want them used, then we could certainly consider putting excludes notes, and if we do want them used, then having a use additional code note would be appropriate. So notes to clarify that would definitely be helpful. And
Okay, and secondly, and this is a comment from the American Hospital Association, for any of these proposals that are looking for an implementation October 1st, 2014, we just think that it would be way too difficult, too confusing to introduce changes at the last minute, and literally that would be at the last minute because it would be a few months before we were supposed to go live. And people have been encouraged to start testing, and next year they should be doing all the testing, whether it's providers, payers, vendors, and so on. And anytime you change something, when something goes wrong, it becomes very difficult to figure out where something broke, and to try to introduce new codes a few months before going live, it would either mean those changes will not get tested and we'll have chaos when something goes wrong, or people will have to retest everything that they've done, which, it sounds almost impossible when you're talking about just hospitals alone. We have 5,000 hospitals, and God knows how many vendors that represents, in addition to physician offices and so on. So we have gone on record as part of our IPPS comment letter that we very much urge not to have any code changes for ICD-10-CM or PCS October 1st, 2014.
okay, thank you. And again, we'll encourage everyone to put all these comments in writing, and we'll look to see those also. Email is good, as was said earlier.
Good morning, David. Jim Nagel, Upper Chesapeake. Two questions come to mind. One is, how do we handle interoperative fractures? I mean, I'm most familiar with preparation for the femoral component, and occasionally when they're putting a stem in, it either cracks or breaks. Yeah. Is that going to be written off as not a complication, or it's going to get, I don't know how that would be handled.
It would be considered, from the input from AAOS, the intent was that would be at M96-6, and that was one of the things that was to be excluded, as that excludes 2 note. The M97 would have an excludes note that was intended to cover that kind of a situation back to the M96-6.
Okay, now secondly is I'm not so clear that these proposed codes in the M97 are the way to go, because I'm not really too pleased with the idea of saying periprosthetic fracture around the left hip joint, etc., because I'd really like to know what's fractured, not around the joint. I mean, because there's a number of bones that could be fractured. I mean, the pelvis could be fractured, the femur could be fractured, which is usually the cause in a hip joint. But, I think that in trying to increase the granularity here, I think just going to a general term like joint doesn't provide enough information.
Okay, so concern about how specific this is, whether we need more information. Okay, I appreciate that. Sue.
Sue Bowman, American Health Information Management Association, and I just wanted to completely support the comments that Nellie had made. Our association also does not support any code changes in 10-CM or 10-PCS on October 1st, 2014, and I'm going to spare you all having to listen to me at every single proposal by just making a generic statement now for all the reasons that Nellie mentioned, to be trying to introduce new codes, and this one is kind of extensive. Even a minor change, we hear from our members, from payers, from others, is just astronomical when you have to go into all the different systems, all the different policies everywhere, and you're trying to worry about testing and getting the ICD-10 implementation right, and now you've got new additional changes going in on exactly the same date. Just sets up a recipe, I think, for disaster.
Okay. Okay, thank you. Any other comments or questions or thoughts on this? All right, seeing none, we will move on. And for those following along, we will now go to page 16, periorbital cellulitis, periorbital or preseptal cellulitis. And this is particularly of interest in contrast to orbital cellulitis. A cellulitis around the orbit of the eye and the preseptal area of the face is a somewhat unique type of a diagnostic concern as compared to cellulitis in other areas of the face or cellulitis of the orbit itself. A periorbital cellulitis is in front of the orbital septum. Now, the orbital septum comes from the frontal bone down to the eyelid, the tarsal plate of the upper eyelid, and an orbital cellulitis is called also a postseptal cellulitis, and that can affect the eye and the orbit itself. It's generally a more severe infection and can require an IV antibiotic treatment, while in comparison a periorbital cellulitis affects the area around the eye and the face, but it does not affect the eye directly, and it can usually be treated as an outpatient instead of as an inpatient with IV antibiotics. So just differentiating those two. And other cellulitis of the face would usually also be able to be treated as an outpatient and would not be as severe as an orbital cellulitis. So the main concern here was sometimes there can be a little difficulty telling, is this orbital or periorbital cellulitis, and you have to watch a little closer on a periorbital one. So it was thought useful to be able to differentiate periorbital cellulitis from facial cellulitis. And sometimes these have been lumped together. Unfortunately, World Health Organization has tended to lump the periorbital cellulitis together with the orbital cellulitis, and that's something our clinicians have told us they do not think that's appropriate at all, and so they want to see those separate. So because periorbital cellulitis can require more intensive evaluation and management than just a simple cellulitis of the face, and also to help clarify how it fits in with comparison to orbital cellulitis, American Academy of Pediatrics requested a unique code to better identify and track the periorbital cellulitis. So this is proposed at category L03, cellulitis and acute lymphangitis, and L03.2 involves the face and neck, with 0.21 being cellulitis and acute lymphangitis of the face. And it is proposed here to add a new code, L03.213, for periorbital cellulitis and preseptal cellulitis, to be an inclusion term there. Also, we would add an excludes to note for cellulitis of the orbit and abscess of the orbit. These would both go to H05.01, which is where the orbital cellulitis goes. While we don't show that here, we could also propose a reciprocal exclusion note at H05.01 to exclude this new periorbital cellulitis and help clarify that the two are separate concepts. So while we did not show that originally, it could be of value to help to differentiate the two. I will also acknowledge that World Health Organization has combined these. Again, our clinicians, from the clinical standpoint, do not feel that's appropriate. But for purposes of somebody wanting to compare statistics with other countries, they could take numbers from both of these and add them together to compare to someone who was combining them, just as a statistical exercise in comparison, if you like. All right, do we have any comments on this, either clinical comments or questions, or coding comments or questions? We'll take both at once. All right, well, we'll let you think about this and see whether you think it's a good idea and comment to us in writing. Certainly, I saw at least one person nodding their head. They thought this was a good idea earlier. Do people in general think this might be a good idea? Show of hands. Hi. Yeah. Nice of you to wave at me. Okay. Yes. All right. Anyone who thinks this is a bad idea? No one thinks it's a bad idea, at least. Well, that's probably a good thing then, at least. We'll invite everyone to put your thoughts on this in writing, and we'll hope to hear more from you on this later. And at this point in time...
I do have a comment.
Oh, yes, go
Darlene
ahead.
Hyman from Upper Chesapeake Health.
Yes.
I do agree with changes not coming up October 1, but in the index currently, there is no guidance for the coder where to code periorbital cellulitis, and I do see that frequently. Mm-hmm. So the coder's either going to pick face or they're going to go to orbit, and I just think there needs to be something in the index to direct the coder, even if there's not going to be a new code October 1 of 2014, just so we can at least get it to the right body system.
So that would be your thought at this point, that it might be useful to have something like that.
I think at a minimum we need something in the index for that site.
That's
there's only orbit.
Point or question. And would something like a coding clinic statement or response on that be helpful? I guess that would be one of the other questions that might be of interest in general. If we don't do an index change or something that actually points people there initially, would a coding clinic article on this be helpful? Any comments? And Nellie would...
Just a point of clarification, Nellie Lee, and she's saying we actually did have a question related to this come through the Coding Clinic Editor Advisory Board. So if it hasn't been published already, there's one in the works. So, I mean, that would be an interim answer until we have something more solid. Okay.
And yes, I do recall that coming through, that I don't know if that had any bearing on why AAP submitted this. It came from AAP, but we did have some discussion of that also. And again, Nellie would probably know more about when it might be published than I would, but I guess it hasn't as yet been published, but we will be looking to at least have that. And certainly we'd be happy to take the ideas of indexing sooner into consideration. I don't think we have that indexed at this point, as you said, Darlene, so it's something to look at. So, all right, and having covered those issues, we'll be moving next to page 17, observation and evaluation of newborns for suspected condition not found, and I am going to turn the podium over to Cheryl Bullock.
Good morning, everyone. My very first official proposal is found on page 17, observation and evaluation of newborns for suspected condition not found. Thank you, David.
My apologies.
It helps me breathe while we're doing this too.
Sorry. Don't mean to leave it too high there. It was.
Okay, again, it's found on page 17 of your proposal package. Currently, in ICD-9-CM, there are unique codes to show an encounter for a suspected condition in a newborn that is ruled out. ICD-9-CM, category V29. These codes explain a uniquely different set of circumstances than those for maternal conditions as the cause of newborn morbidity and mortality, ICD-9-CM, category 760. In ICD-10-CM, this can only be coded using codes in category P00, newborns suspected to be affected by maternal conditions that may be unrelated to present pregnancy. However, it was felt that category P00 does not represent the same concerns as in ICD-9-CM category V29. The American Academy of Pediatrics requests that a unique set of codes be added to ICD-10-CM to more clearly capture this information. The original requester suggested the use of category Z03. However, this category is in use by WHO ICD-10 and cannot be redefined to meet the needs of this request. There are two things I like to point out with this proposal as it relates to the P00 category. Number one, a revision has been proposed to the note at P00, newborn affected by maternal factors and complications of pregnancy, labor, and delivery, code range P00 to P04, and which the last portion of the note has been deleted. The revised note states, codes from these categories are also for use for newborns who are suspected of having an abnormal condition resulting from exposure from the mother or birth process, but without signs or symptoms. So basically, we're deleting the last portion of that, and I'll explain that a little bit more later. In addition, an excludes one note has been proposed at the P00 category level, which will state, encounter for observation of newborn and suspected diseases and conditions proven not to exist, which will be our Z05 category. Which the 05 new category, which is the proposed new category, we will add a note that will state this category is to be used for newborns within the neonatal period for the first 28 days of life who are suspected of having an abnormal condition resulting from exposure from the mother or birth process, but without signs or symptoms, and which after examination and observation is not found. The uniqueness of that information is that what we're trying to provide is that P00 will be for conditions that are not ruled out. Again, P00 for conditions not ruled out, and the proposed new category Z05 will be used for conditions ruled out. In addition, for category Z05, an excludes note 1 is being proposed, which will state newborn observation for suspected conditions not ruled out will be that excludes one note. There are a proposed 6 new codes that will fall within the Z05 category. Outside, you have those codes in your packet with one correction. When we went through the packets again, we noticed that Z05.1 was deleted in error. So we will make that correction, but we have basically made the codes, developed the codes that would be comparable to what was in ICD-9-CM. So that's what we were trying to do. So, floor is open for comments.
Sue Bowman from AHEMA. Well, I just should go on record as saying I hate P00.
Okay, thank you.
I hate it slightly less now, but I'm still kind of like not ruled out, I don't know. But one thing I would point out is I think it should be an excludes 2 note in these 2 categories, not an excludes 1, because you could have 2 different conditions, one that is not yet ruled out and a completely different condition that has been ruled out that would be classified to these 2 categories, so you wouldn't want to prohibit being able to assign both codes.
Okay, thank you.
I'm Linda Holtzman, Clarity Coding. First, I have to tell you a funny story.
Sure, I can use funny.
Yeah, I took my kid to the ER, like, I don't know, 17 years ago or something like that, and I don't even remember what his symptoms were, and the pediatrician there gave him this whole thorough review, and she turned to me and said, he has something we call NPS. And I said, what is that? And she said, new parent syndrome.
It's not a new code. We get that.
So anyway, I thought this is a good idea, but I'm getting myself confused here. How does this, if we have the P00 for those conditions that are not ruled out, how does that fit with the coding guideline on uncertain diagnoses? And where I'm going with this is, I code a lot of cases where the newborn, the mother has some kind of infection or whatever, and there's a concern that the newborn has sepsis. So the newborn goes to the NICU, and they do all kinds of cultures and workups, and after 2 days or 4 days, everything comes back and it's fine, and we're done. I mean, I get a lot of cases like that. And right now I'm just throwing on V29.0 and got on my merry way. But if they say they couldn't rule it out, I just code sepsis, newborn sepsis. So my question is, which of would I code, if they haven't ruled out sepsis for this newborn, would I code sepsis? Would I use the P, or would I use a P00?
P00, am I right, Ms. Thomas? I was ruled out, it would be one of the P codes.
No, this is not ruled out. They're still thinking, they're not sure, the cultures were equivocal, so they're still considering, sometimes you see them documented as like empiric, In other words, just going on what they've got at this point, they can't rule it out, so they're going to keep them on a 10-day, course of antibiotics. Well, as far as I know, that would meet the requirement for an uncertain diagnosis, and I would just go ahead and code the sepsis. So if we now have this hated category of P00 that is for conditions that are not ruled out,
right,
that to me seems there's too much overlap between that and the uncertain diagnosis guideline, and that would have to be worked out. I don't know what to code at this point, but this is such a common. I don't know that I have a suggestion at this point. I'm just saying that it's such a common scenario to have newborns where there's a suspected of sepsis because of something going on with the mother, and then they invest a fair amount of workup in this. There's got to be a way to show that, but sometimes they can't decide if they have it or they don't. At this point, at least according to the uncertain diagnosis guideline, you'd have to code the condition. I don't know when you'd use the P00 for not ruled out. So that has to be sorted out. And then my other question is, what you said that the proposed new code Z05.1 was inadvertently removed from this? What?
On the packet, in the printing and the revision of the packet. But it will say Z05.1 will just say encounter for observation of newborn for suspected infectious condition.
Okay, so that ruled out. Okay, because it's under the heading of ruled out. So
that's correct.
Okay, that I'm good to use that code for when everything comes back negative after 2 days and they take him off the antibiotics and he goes home. Okay, that's good. The problem is when it's not ruled out.
The P
okay,
code.
Thanks.
Thanks. I guess we'll take back, my takeaway would be we'll take a look at the guidelines as well as just making sure it's clear about the P00 category. Yes, ma'am.
Hi, Becky Dolan, American Academy of Pediatrics. We put these codes forward, and I think the Academy's intent was that the P codes were for those conditions that may or may not have been ruled out at time of discharge, for those conditions specifically related to the maternal issues, birth process, versus what we see in the Z codes were those conditions that are unrelated to the birth process. It might be environmental factors that have confounded the baby within the first 28 days of life, and for those emergency room visits where the baby's being brought in and there's nothing they can find that is wrong, as well as when they present to the pediatric office, which again, it's a lot of NPS, and that's very common. So I think our intent was really to separate out the two. One is strictly related to maternal and birth process versus the Z codes. So it wasn't necessarily a differentiation between ruled out and not ruled out. It was a differentiation of the etiology. Was it a result of the birth process? Was it a result of maternal complications? Or is it something unrelated to the birth process, which is where the Z codes are?
Thank you.
Jim Nagel, Upper Chesapeake, as a former pediatrician, I agree with that because I think this linking it to the maternal condition or the birth process in the first 28 days is kind of a stretch. I mean, I think once they go home, I think that should probably stop calling it that. The other thing I would suggest is these Z05 codes should get an addition at the end saying adding condition found not to exist. I mean, it's up in the header, but it's not in each one of the titles, and I think that may be not noted.
Thank you.
Okay, Linda had a good point. I mean, it could say, you know, like encounter for observation of suspected neurological condition, and it should say like ruled out or found not to exist, whichever one you like. She likes ruled out.
Okay.
I mean, because you always want to err on the side of conservativeness here. I mean, some parent comes in and says, you know, my baby stopped breathing 6 times, and the baby looks fine, but you're not going to send them home. I mean.
Just as a side note, though, in the new category title Z05, we did indicate encounter for observation of newborn for suspected diseases and conditions ruled out. So it is stated there, but I do understand what you're saying.
Yeah, you know, we saw that. The problem is sometimes you don't necessarily look at the category heading, so it would be, you know, it's a suspenders and belt kind of situation.
Okay.
It would be helpful if after Z05.2 it says, you know, encounter for observation newborn suspected neurological condition, comma, ruled out.
Okay.
And then say ruled out after each of these. Thanks.
Thank you. Any other questions, comments? All right, on to proposal number 2, which is found on page 19, which is also from the American Academy of Pediatrics, vaccine and prophylactic immunotherapy administration. Again, found on page 19 of the packet. The American Academy of Pediatrics requests that Z23, encounter for immunization category, be expanded to better identify the reason for the vaccine encounter and include prophylactic immunotherapy. It is noted that one code corresponding to ICD-9-CM categories V03 and V06 is present in ICD-10-CM, which is code Z23. However, AAP indicates there is a need to provide greater specificity regarding why an immunization is being administered. It is also noted that all immunizations, vaccines, serums are given as a part of routine preventive health visit. The administration of prophylactic immunotherapy as a reason for the encounter needs to be monitored. NCHS has received correspondence from CDC programs and the Department of Defense supporting the need for expansion of these coding categories. The codes presented in this proposal are an expansion of category Z23 with a revision of the code title to state encounter for immunization against single bacterial disease. In addition, 5 new code categories are being proposed. Z24, encounter for immunization against single viral disease. Z25, against other single viral disease. Z26, against other single infectious disease. Z27, against combination of infectious disease. And Z29, encounter for other prophylactic measures. For categories Z23 to Z27, the codes proposed also include encounter for immunization of diseases that were included in the ICD-9-CM code, as well as additional diseases which were requested at the request of AEP. In addition, codes have been created for encounter for immunization against other specified single bacterial and viral infectious disease, unspecified single bacterial and viral infectious disease, and immunizations against combinations of infectious disease. It is important to note that within categories Z23 to Z27, there are specific coding instructions proposed that includes 1, a revised first note that states, code first any examinations such as routine childhood examination if applicable. Z00.12-. And also it excludes one note that states, encounter for immunization against combinations of infectious diseases, Z27. For the new proposed code category Z29, encounter for other prophylactic measures, there is an exclude one note that excludes the coding of desensitization to allergens, Z51.6, and prophylactic surgery, Z40. You will note that code Z51.6, desensitization to allergens, that code is new and will be, my coworker Shannon will come and discuss that code clarification as well. So again, for code new subcategory Z29.1, encounter for prophylactic immunotherapy, with the inclusion term encounter for administration of immunoglobulin is also being proposed. New codes for this proposed subcategory include, and you will see in your packet, they range from code Z2911 to 14, as well as Z299. And again, different disease processes have been identified at the request of AEP, which codes have been developed for. And you, yes, sir. Any questions?
Jim Nagel. No,
Yes, sir.
not a question. I
Sir.
think that I may share the opinion of a number of people, and I don't want to point any fingers, but it was kind of shocking to see the lack of specificity for this code. I mean, it was just originally came out with immunization, period.
Yes,
and like, wait a minute, what's going on here? And this is, I think, a well-founded attempt to fix it. I mean, the only 2 or 3 things that I would comment on is, one is I think you should, I mean, the American Academy of Pediatrics is weighed in, but I think you also should look at the recommendations of the ACIP to see which vaccines that they're recommending and make sure those are specifically named as encounters for. I mean, the one I noticed specifically missing is meningococcal vaccination, which is missing off this list. The other question, and another one that's missing, although is perhaps not as clear, as whether you want to do something with rotavirus. The other question is whether you want to include seasonal influenza immunization in this section.
Okay.
Since a lot of, I mean, it's kind of a hospital policy that most of us have to get it, whether you like it or not.
Okay. Thank you. And please, I know the standard answer is please submit those suggestions in writing so that we can definitely take a look at it. Thank you.
Darlene Hyman, Upper Chesapeake Health. Sorry, Jim, I don't know if I like this. And the reason is because a lot of this can be captured through the procedure code. And that's the only point well, actually, I do have another point. I do like the prophylactic, the Z29, and I love the ROGAM immunization, because actually I wrote to coding clinic about that. So that's all. Thank you.
Thank you. Sue, before you start, I wanted to pick up on a point that Jim had made about, the code not being expanded in 10-CM and all the detail was lost. I think there's a philosophical issue here about what the code was or wasn't to include. And based on Darlene's comment, I think that's part of the issue. Early on, we received comments that many of these combinations or single immunization could be coded with a procedure code, and that what was actually happening was that in the diagnosis codes, you were carrying over procedure-related information. The other thing that we found challenging in ICD-9-CM was every time there was a new combination created, there was really no way to keep up with the amount of things that people wanted to see represented in diagnosis codes, though there were procedure codes that adequately identified those things. But we also know that for some of these things in an inpatient setting, CPT codes aren't being used. It's the ICD-10-PCS. So at this point, we've got, I would say, several different philosophies regarding what should or should not be in the diagnosis classification. So I think we would also love to hear specific comments not only to the proposals that Cheryl is presenting, but full opinion about whether things should be in a diagnosis classification versus something that should be in a procedure classification.
Sue from HEMA, and my comment isn't on that issue. I'd have to think about that a little bit more, but mine's on a more basic issue, I guess because of some unintended consequences that have come up recently about what started as a great idea to have excludes one and excludes two distinctions and has resulted in all kinds of grief, as Donna knows well. So I'm just wondering whether this is appropriate as excludes one notes here, because I haven't examined all the combinations between the single bacterial diseases and what's in Z27, but I guess I'm wondering, could you have a combination that's in Z27 but also be doing a single disease from one of the other categories that's not included in the combination code, and now you're saying you can't code them together? And the same with the excludes one note for immunization not carried out. What if you carried out one but not the other? Wouldn't you want to capture both circumstances? And so I think we need to think about whether this should be excludes two rather than excludes one. I've come to the conclusion that a real excludes one is pretty limited, because otherwise you've locked yourself into a box of not being able to use any of the codes in those categories together when that may not be the original intent.
Thank you, Sue.
Nellie at the AHA, I agree with Sue, and actually I didn't know that's what she was going to say about the excludes two note, but as I was flipping through, I did think of a situation, and I don't know if clinically this happens, but I saw, for example, the encounter for immunization against MMR, measles, mumps, rubella, and let's say you would want a tetanus shot as well, and that's a single, and I didn't see a combination that included MMR and tetanus. So I think that would be a good example of, when you would want to make sure it's an excludes two note. My other comment is really about the Z2381, which is immunization against Haemophilus influenza type B. And that seemed very specific to me, and this perhaps is a question for the CDC or other clinicians. Are there ever possibilities for different types, besides B, A, C, D, or whatever? Because actually, if that's the case, the CPT codes would give you specific information about what the vaccination is. But, why lock ourselves so specifically in the diagnosis code to a specific type of influenza vaccination? Thank you.
Thank you, Nellie. I was just going to ask if AAP had a comment. Thank you, Becky.
Yes, the AAP has a comment. When we originally submitted the proposal, it actually looks nothing like it turned out. When I started teaching our coders that we were only going to have one code for vaccines, I heard a lot of sighs of relief, because there's been a lot of confusion, a lot of angst. We didn't have enough room to put all the codes. When you're talking about a 2-month getting vaccines, there's a lot of vaccines and a lot of different codes. The original intent behind this proposal was to really set aside those vaccines that are given routinely for those patients, both as adults and pediatric patients. What we wanted to capture were those vaccines that were given at other types of settings, in the emergency department, inpatient, so you're looking at things like the tetanus, rabies, etc. We never really intended to pull all of the 9 codes over. In fact, I think I might have a lot of angry people if I tell them we're going to do that. So I think a lot of revisions might have to be done, just taking a look at it and looking at the schedule right now as it stands with ACIP and AAP for recommended vaccines for pediatrics and adults. So I think that we might have to take a look at this again, because I think having a single category code, because like a lot of people have mentioned, in the outpatient setting, we do have product codes that we link, and most people have been very happy with that. So I think it's...
Thank you. Other comments, questions? Well, we look forward to receiving all of your comments in writing on this, and I'm now going to go sit back in my chair. Thank you.
And now I get to introduce and turn the podium over to Shannon McConnell-Lamptey. She will continue with the additional proposals. Thank you.
Good morning. If you'll turn in your packets to page 23, the topic is Encounter for Prophylactic or Treatment Measures. The American Academy of Pediatrics feels strongly that there needs to be a clear way to track these encounters, as they can have a significant effect on the patient's health care as well as quality metrics. So we are proposing to revise the title at category Z51 to read Encounter for Other Aftercare and Medical Care. And as Cheryl mentioned earlier, we're also proposing to add a new code, that code being Z51.6, Encounter for Desensitization of Allergens, which would be an excludes note under category Z29, which is Encounter for Other Prophylactic Measures. And I just want to state, before opening it up for comments, that the reason behind having this one code moved over under category Z51 is that it already exists under World Health Organization as a code. So we just wanted to bring that over under this specific category as opposed to the Z29 category. Any comments, questions? Hearing none, I'm going to turn the podium back over to Cheryl.
Okay, I'm back. My third proposal is found on page 24 regarding conductive and sensorineural hearing loss. The current coding structure of ICD-10-CM does not allow for mechanism for reporting different type of hearing loss conditions in each ear. The codes for unilateral hearing loss, H90.1, 90.4, and H90.7, specify an unrestricted hearing condition on the contralateral side. The development of unique codes is needed for better reporting when the type of hearing loss is different in each ear. This proposal was submitted by the American Academy of Audiology and is supported by various professional disciplines, including the American Academy of Rehabilitative Audiology, the American Speech Language Hearing Association, the Academy of Doctors of Audiology, the Academy of Otolaryngology, Head and Neck Surgery. It's important to note that the requester is asking that these changes be implemented during the partial freeze. So again, NCHS is asking for commenters to definitely address that issue. So the proposed codes that are being presented at this time, under section H90 to H94, disorders of the ear, a new subcategory is being proposed, H90.8. Under H90.8, there will be 3 new subcategories. Basically, we're taking conductive and sensorineural hearing loss with restricted hearing on the contralateral side. So for each type, we do have conductive hearing loss, unilateral H90.81, sensorineural hearing loss, unilateral H90.82, and mixed conductive and sensorineural hearing loss, unilateral with restricted hearing on the contralateral side. So under each subcategory, these codes have been developed to show hearing loss with laterality, showing restricted hearing on the other side. There's also a new code note instruction that will state, use 2 codes to show different type of hearing loss on the contralateral side. This way, you can allow for coding to show, again, 2 different types of hearing loss on each and the laterality of the affected ear. Again, we're also, the important thing to remember here also is that we're asking for written comments because it was specifically stated that they want these codes effective during the partial freeze. Any comments? The floor is open. Okay, moving right along. My last proposal is found on page 26 regarding somnolence, stupor, and coma. Page 26 of the proposal. Basically, this proposal that was submitted by the American Academy of Neurology is proposing that R40.24 Glasgow Coma Scale total score be added to the list requiring a 7th character. There's currently instruction at R40.2 coma to add a 7th character to R40.21, R40.22, and R40.23 to describe the time when the Glasgow Coma Scale was administered. R40.24 was added when it is to be used when only the total Glasgow score is recorded. However, these codes were not included in the 7th character instruction. So with this modifications of this category would also include the following proposed revisions. At subcategory 40.2, coma, there is a revision of the coding note which will now read as one code from each subcategory, R40.21 to R40.23, is required to complete the coma scale. So in addition to adding the 7th character to code 40.24, there are two other proposed changes. The deletion of the code note, use codes R40.21 through R40.23 only when the individual scores are documented. That note will be deleted with a revised note that will state, assign a code from subcategory 40.24 when only the total coma scale is documented. Comments? Questions? Yes. Okay, I'm done. Oh, darn, yes.
I think I understand what you're saying. Just want to be sure I do. In other words, if you have a full coma scale, you should be using 3 codes, one for each of the 3 subcategories. But if you only have a note that says, GCS 12, then you use from the R40.24. That's right?
Yes, ma'am.
This is kind of, Jim Nagel, this is kind of a peripheral issue, but I think has come up already in our discussions, and that is who's going to document the coma scale scores? I mean, it's not going to be the physician in most cases, so what are you going to use for acceptable documentation for this?
ER record? I said ER. Yeah, yeah.
I don't have a book in front of me, but I believe that there are notes in the tabular that specify when the score is taken and in what environment, whether it's in the ambulance, et cetera, et cetera. So there's a way to indicate that already. And I'm not sure if we have anything in the guidelines specifically about that, but there is instruction in the tabular so that you're actually identifying where it came, who actually provided it, or at least the setting that it was provided in, which gives you an indication of who likely documented it. Sue?
I was just going to add that we have recently gotten actually several questions at the same time asking that we address that in the next version of the guidelines, as far as specifically saying where they could take the Glasgow Coma score from, because we don't specifically say that it doesn't have to be the physician, even though it's pretty common that it would not be the physician.
Thank you for that comment, Sue. Darlene, I think you want to say something.
I know, I'm trying to find it and I can't. Sorry, but Donna, just like you had said, that's how I took it. I thought, well, you take it where it's documented. But this actually came up recently where, at a training, an I-10 training session, this debate came up. And I read the guideline and the instructor didn't see it that way. So.
Okay. Well, that's good to know, because that will really facilitate discussions when we start to look at the guidelines, because obviously when we're looking at making changes to the classification itself, we're also looking at the need for new guidelines or a clarification if some language is already there. So that's very helpful, and make sure you put it in writing. Okay, no other questions on this? Okay, thank you, Cheryl.
Thank you.
And thank you, Shannon. They were very nervous, but I think they did a fantastic job. And with that, I'm going to turn the podium to David, who will present the next topic.
Okay. Well, since we've had so much time to do things here, we're going to move back to the later part of the topic packet again, to dental terms on page 55. We'll be covering some of those next. So again, those who are following along, we'll look at page 55. And dental terms here, just broadly, and first I will be covering a few different dental terms. And we had a number of proposals from the Harvard School of Dental Medicine to add a number of dental terms to ICD-10-CM. And basically they want to get both more detail and more up-to-date terms in that match up with the sets of oral health terms that they use. They want these in ICD-10-CM. And from the dental standpoint, this should enhance the clinical relevance of the ICD terms for dentists and also has potential to help increase the utilization of ICD among dentists. And further rationale they had for groups of terms will be looked at for each of these separately. And they did have a number of things, both periodontology, endodontology, and terms related to caries, as well as a few other ones. And there probably are some other ones that we're not addressing now that you may get to hear about in March even, just so you have something to look forward to. All right. So periodontology related terms. There's a number of things related to dental plaque and plaque-induced gingival disease. And we're proposing to add some terms at K05.00, acute gingivitis. That's acute gingivitis plaque-induced. And we would propose to add terms for plaque-induced gingival disease. And we would have non-essential modifiers for with local contributing factors or also without local contributing factors. Also, it's proposed that at K05.1, chronic gingivitis, we add an inclusion term for pregnancy-associated gingivitis. This is a specific type of gingivitis that's found commonly in pregnant women. Also at code K05.5, other periodontal diseases, it's proposed to add a few terms here. First, the term combined periodontic endodontic lesion. This type of lesion occurs when an infection involves both the pulp and the periodontal ligament space at the same time. Also, the term primary occlusal trauma. This results from an abnormal occlusal forces on the teeth with normal periodontium. Also, the term secondary occlusal trauma. And this type results from normal or excessive occlusal forces on teeth when there is abnormal or compromised periodontium. We would also add the term insufficient biological width with the non-essential modifier for of periodontal soft tissue. And this is the dimension of the soft tissue attached to the portion of the tooth coronal to the alveolar crest, which is essential for preservation of periodontal health and removal of irritation that might damage the periodontium. When this width is insufficient, it's a strong indication for crown lengthening. Now, in addition, it's also proposed to add some terms at K06.8, other specified disorders of gingiva and edentulous alveolar ridge. Specifically, it's proposed to add additional terms for horizontal ridge deficiency and vertical ridge deficiency. These are deficiencies in the width and the height of the alveolar ridge, respectively. All right. Any questions or comments on these? I recognize we don't always get as much interest on the dental community. And I'll have to admit, I'm not a dentist, so this has something for me to think about as well as for you. So, have we given you something to chew on? Oh my. All right. Well, seeing no comments on this one, and I'll invite anyone to comment or come forward if you'd like. But if there are no comments on this, we will move on to endodontology-related terms on page 57. Endodontology classification considers both symptoms and reversibility, and both of these have implications for clinical management of a patient in cases where there's endodontology-related problems. Right now in ICD-10-CM, we have the same code, K04.0, for both reversible and irreversible pulpitis, and it is proposed to differentiate these two concepts and have separate codes for them, since these diagnoses have significantly different treatment implications. First, reversible pulpitis is a condition where the pulp is inflamed and it's actively responding to an irritant, but the pulp is still considered to be vital. So once the irritant is eliminated and there's placement of a restoration, then the pulp will return to the normal and healthy state. It can be either symptomatic reversible pulpitis involves pain, or it can be asymptomatic, and asymptomatic reversible pulpitis involves no symptoms. Next, irreversible pulpitis, broadly, is a condition where the pulp is irreversibly damaged. While the pulp is still alive, introduction of bacteria in the pulp would not let it heal, and it will ultimately result in necrosis or death of pulp tissue. Treatment in such a case is usually extraction of the tooth or endodontic treatment. Now, there can be asymptomatic irreversible pulpitis or symptomatic irreversible pulpitis. Looking next at the proposed changes to the tabular, this is at K04 category, and it is diseases of pulp and periapical tissues. At K04.0, pulpitis, it's proposed first to delete the two terms irreversible pulpitis and reversible pulpitis and separate those as separate codes. We would have a new code, K04.01, for reversible pulpitis with inclusions for asymptomatic reversible pulpitis and symptomatic reversible pulpitis. We would also have a new code, K04.02, for irreversible pulpitis with the inclusions both asymptomatic irreversible pulpitis and symptomatic irreversible pulpitis. And that covers the changes we would have. Any comments or questions on clinical aspects of this or on the coding changes proposed? This would involve new codes. Many of the changes that we have here are really just, in some respects, addenda changes where we would add terms to particular existing codes. Any comments or questions on this? Seeing none at this time, we'll move on to dental caries. Now, dental caries, as you know, are cavities. That's what we always think of them, other than dentists, of course, call them caries, but I think most others just call them cavities. Recent trends in caries diagnosis require indication of the extent of the decay. Following principles of the International Caries Detection and Assessment Systems, or ICDAS, which is a detection and assessment system for classifying the stages of the caries process. Now, following these principles, the Harvard School of Dental Medicine has recommended addition of a number of terms related to dental caries that are in line with current thinking in the field. And these are more robust in their description of dental caries diagnoses than the ones we currently use. And I'll look at these in some detail, and I'm going to cover these both looking at the description and the codes at essentially the same time. So I'll be skipping forward and down if you like here. First, arrested incipient caries in enamel are non-cavitated and inactive caries. These can involve white spots or brown spots with pits and fissures of the enamel. They may be separated based on depth into those that are halfway to the dentino-enamel junction and those greater than halfway to the DEJ, the dento-enamel junction. Arrested incipient caries may also involve caries lesion regression or remineralized caries lesions. And looking at how we would be handling arrested incipient caries, well, first we have in ICD-10-CM, we have K02 dental caries, and there is a K02.6 dental caries on smooth surface, and at K02.61 we have dental caries on smooth surface limited to enamel. So it would be proposed to add a term there for active incipient caries in enamel with non-essential modifiers for less than halfway to the DEJ, and also a separate non-essential modifier for greater than halfway to the DEJ. And again, that's the dentino-enamel junction. Next, okay, that one was for, sorry, I misspoke there. I'm getting ahead of myself. I talked about active incipient caries, and I'm also talking about arrested incipient caries, which are two slightly different things. I first talked about the arrested incipient caries, and I misspoke on those. I intended to say at K02.3 we have arrested dental caries, and there we would add a term for arrested incipient caries in enamel with non-essential modifiers for less than halfway to the DEJ and greater than halfway to the DEJ. So those would be at K02.3. So these are arrested incipient caries. We also have active incipient caries in enamel. Again, these are non-cavitated but progressive caries, and they can also involve white spots or brown spots with pits and fissures in the enamel. And they can be separated based on depth, as we'd said, into those that are halfway to the DEJ or greater than halfway to the DEJ, either less than or greater than. The arrested ones basically are inactive. They're no longer progressing. The active ones are progressing. So that's the difference between them. Again, the arrested ones would be at K02.3, arrested dental caries. The active ones would be at K02.61, the dental caries on smooth surface limited to enamel. Active incipient caries in enamel to be added there, with arrested incipient caries in enamel to be added at the K02.3. And again, the difference between these is that the arrested ones are not progressing, they're inactive, while the active ones are progressive, getting worse and getting deeper noticeably, as it were. Next, looking at primary caries. Primary caries at the DEJ, the dento-enamel junction, again, are initial caries extending to the dentino-enamel junction. And at K02.5, we have dental caries on pit and fissure surface. K02.52 is dental caries on pit and fissure surface penetrating into dentin. And we would propose to add the term primary caries with parentheses at DEJ at K02.52. Next, we also have a number of other terms which are descriptive of caries but are not as useful in differentiating between the different separate ICD codes that we have within the K02 category. And we would propose that these be added just broadly under the category of dental caries. And I'll go through these separately. First, recurrent caries are caries around an existing restoration which may have depth into the enamel, to the DEJ, or to the pulp. And this would be one of the terms that would go to dental caries. We would add recurrent caries with non-essential modifiers for DEJ, for enamel, and to the pulp. We also have early childhood caries, which is the occurrence of any sign of dental caries on any tooth surface during the first 3 years of life. We also have rampant caries, which is an advanced or severe decay on multiple surfaces of many teeth. And we also have caries of dentine. This is dental caries extending into the dentine. We also have pre-eruptive caries, which are defects on the crowns of developing permanent teeth, which are evident radiographically, even though there's no infection of the primary tooth apparent. So all of these terms would be proposed to go just broadly to K02 dental caries. We would be adding caries of dentine, early childhood caries, pre-eruptive caries, recurrent caries, as I'd said, with non-essential modifiers for DEJ, enamel, and to the pulp, and also adding rampant caries. All of these just directly below K02. And again, we would add the other terms mentioned at specific spots here at K02. All right. Any comments or questions on these terms related to dental caries? Sue.
Sue Bowman from Mahima. Just one really quick comment. I would recommend spelling out DEJ because I would have had no idea what that stood for.
Okay. I think that's a reasonable thing for us to contemplate doing, and it shouldn't be too hard for us to do. So spell out DEJ. That sounds like a good thing. All right. No other comments, questions, or thoughts on these? Seeing none, I will move on to page 59. Other dental terms in your handout for anyone following along. Now, there are a number of other dental terms submitted for inclusion that do not fall under any of these broad categories that we've already talked about. And in these cases, there's no matching terms in ICD for what are apparently fairly frequently used dental terms. So they are proposing we add inclusion terms and or indexing for certain of these. These conditions can be common indications for some commonly done dental surgical procedures that they have, things such as crown lengthening or tooth extraction. And we'll look at some specific things here. First, insufficient anatomic crown height is when part of the tooth is covered with enamel extending from the cemento-enamel junction to the cusp tips or the incisal edge, and when this is shortened. So the crown, the top part of the tooth, is shortened, as I understand. There's insufficient clinical crown length when there's an insufficient portion of the tooth above the gingival margin. So the tooth is a little bit shorter. It doesn't extend up above the gingiva as much as at least would be optimal. And finally, a non-functional tooth is a tooth that is not in occlusion with any opposing teeth. So either the teeth are shifted so that there's not one that meets it, or there's a missing tooth. And in either case, the tooth is non-functional if it doesn't have another tooth that it can push against to chew the food. So finally, for tabular modifications on these other dental terms, it's proposed that all of these go to category K08, other disorders of teeth and supporting structures, to K08.8, other specified disorders of teeth and supporting structures. And here we would add terms insufficient anatomic crown height, insufficient clinical crown length, and non-functional tooth. So we would add all of those terms here. Any comments or questions on these? Does all this talk about caries make you want to change what you're planning to eat for lunch? I'm not sure. Well, we are coming to that time in our schedule where we will be shortly letting you go to lunch. Let me check with Donna on whether we can do that just yet.
Thank you, David. Yes, we have reached the time for lunch, and now that you know everything about your teeth, you'll know what to think about while you're eating. Anyway, enjoy your lunch. Please be back at 1:30. We do have other agenda items for today's presentations. See you after lunch.